Hello, I'm Norman Swan. Welcome to this programme on aged care assessment. With our ageing population, services for older people are more in demand. Frail older people, along with their family carers, often require support and assistance at home, or they may need to take the difficult decision to enter a residential aged care facility. The role of aged care assessment teams, commonly known as ACATs, is to assess the care needs of frail older people and to assist them to gain access to the most appropriate types of care, including approval for government-subsidised residential and community aged care services and packages. Now, this programme is going to explore the role of aged care assessment teams in rural and remote communities and the role of primary healthcare professionals in the comprehensive assessment of the needs of older people and their carers. We'll also highlight some of the challenges of ACATs in rural and remote Australia and some of the strategies that have been developed to deal with these challenges. As always, you'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Jane Tolman is a geriatrician and Director of Aged Care at Royal Hobart Hospital in Tasmania. Welcome, Jane.
Thank you.
Jane's formerly a teacher but has trained in both geriatrics and respiratory medicine since. Max Graffin is a General Practitioner in Wagga in New South Wales. Welcome, Max. Thank you. Max has spent the last 9 years as a geriatrician for the Greater Southern Area Health Service and recently returned to blended GP geriatric practice in Wagga, and he's done that for the last 3 years. Deborah Tooley holds a Master of Nursing and has been working in rural New South Wales for the past 24 years with the Aged Care Programme. Welcome, Deborah.
Thank you.
Deborah's currently managing the Far West Aged Care Assessment Programme, which predominantly services remote New South Wales. And Kate Smith is a Research Fellow with the West Australian Centre for Health and Ageing at the University of WA in Perth. Welcome, Kate. Kate has worked for many years in aged care assessment as an occupational therapist and in the Kimberley region of Western Australia. So welcome to you all. Jane, give us the context, the good and the bad news. We're all living longer, but that's part of the problem.
Well, we know what's going to happen in the future, but we also don't know. I think most of us know that the common measure that we use, the percentage of people over 65, is growing. And if we look back to the beginning of our nation in about 1900, only about 4% of us were over 65 years of age. Currently, that figure is about 13%. By 2031 or so, that percentage will be about 25%. Now, those figures are fairly scary, but if you look at the very old, that is...
Well, it's pretty good if you're wanting to live long.
It certainly is. But in terms of services and so on, the percentage of people over 85, however, is not just doubling, as it is for the over 65 years of age, it's tripling. So the expected number of people over 85 by 2051 is 1.3 million Australians.
And of course the pattern of disease is changing.
It does indeed. Many of us will appreciate that in the 19th century, the diseases from which people suffered and died were predominantly those of infectious diseases. So people developed pneumonia and malaria and cholera and so on. The 20th century, again, is history, and not too many people appreciate that. In the 20th century, people suffered from and died with vascular diseases, heart attacks and strokes, and cancers and lifestyle diseases. The diseases of ageing, however, are different from those. So by
the time you get to extreme old age, you've survived all those.
You've survived them.
Or not got them.
Exactly. So the old are less likely to suffer from a range of systemic illnesses and much more likely to suffer from a range of what we call neurodegenerative conditions. And these cover basically 3 general areas: disorders of senses, so hearing and vision will be poor, disorders of balance and gait, so old people are more prone to falling over, and disorders of cognition. Frank dementia in many people, but cognitive slowing in many others.
And Kate, this is happening in Aboriginal people 20 years earlier, presumably.
Yeah, we found in non-Indigenous Australians over the age of 45 that the prevalence of dementia is about 2%, but in the Aboriginal and Torres Strait Islander people we assessed in the Kimberley region, about 12% had dementia, which worked out to about
over the age of
over the age of 45, so about 4 to 5 times more.
And is this Alzheimer's disease or another cause of dementia?
Alzheimer's disease was the most common type of dementia, followed by vascular dementia, which is similar to what you find in non-Indigenous people.
So Deborah, is this just a rapid ageing?
I think so. Older people are getting older, and we now have.
I mean, in Aboriginal people.
Oh, sorry.
Your experience with.
Yeah.
Just this accelerated ageing that Aboriginal people suffer from.
As a result of chronic illnesses and lifestyle issues that they've endured in their communities.
So this is a really high impact, Kate.
Yes. You also see it with falls. I found falls are happening at an earlier age as well. So a lot of people are having these geriatric syndromes at an early age.
And Max, is the demography different in rural areas?
In rural areas, we tend to have a slightly higher proportion of older people, and they tend to be sicker too because they have less access to appropriate health care.
Do you agree, Jane?
Oh, absolutely. Rural and regional Australia predominantly consists of older people. The younger people go off to the city. The older people are left there. Some older people go there to retire. And then there are fewer services. We've got a body of poorer people who have less good health by very definition.
So, Deborah, there's disproportionate pressure on services?
Yes, there is. I mean, in rural or remote areas where people need to travel, maybe days, up to 10 hours and 8 hours, so to get to specialist services, often the thought of sending them there is lost because of the problems and the transport problems and all those things that it takes to actually access people to specialist sorts of services.
So what are the statistics on care needs then in this rapidly ageing community?
Well, sadly, if our bodies don't wear out as we get older, our brains will. And at this point in time, we don't have any cures for that. So we find that if you're in the frail, old age group of 85 plus, about 3/4 of that population have problems with cognition, have problems with mobility, and also need some assistance with the domestic care. And about 1/3 of them actually require help for their personal care.
So the needs are considerable.
Absolutely.
When we talk about frailty, Jane, what do we actually mean?
Well, there's no standard definition of frailty, but frailty is a recognition that old people have low reserve. And so frailty will be a combination of cognitive problems, physical problems, so that might be diabetes, it might be gout, it might be arthritis, predominantly falls and balance, predominantly cognition and predominantly senses. And all of these things interact.
Deborah, give us a sense, before we get on to assessment, what the menu of services looks like.
I think the further you go out from the cities, there's a significant reduction in the amount of services available, and so they're used very wisely. But on the other side of that, smaller communities, rural and remote communities, work very closely together. So often there's a use of informal supports as opposed to always formal paid resources as well. But clearly, as far as health professionals to try and improve the health and lifestyle, there is a significant lack of specialist services, allied health services. In certain towns, for instance, we have a physiotherapist fly in from Sydney every 6 weeks. And you know that they can only do so much. So a lot of the staff who work in facilities and in communities in rural remote New South Wales are very multi-skilled and work often distance. They get their skills from a distance, and we use a lot of telehealth and a lot of video conferencing and things to access services, and it's usually the generalist staff that put them into place.
Max, with this shift of demographics in rural and remote Australia towards an older population, people moving out, does that mean there isn't the pool of carers in the family? The family support tends to be missing.
I think that there are two consequences. One is definitely families tend to be geographically remote from their families these days, if not interstate, then overseas. And the second issue too is that the pool of people that actually do the formal care in the nursing homes or in the home care services, there's not that many young people to actually perform those tasks. So it's a double whammy.
Deborah, do you think people understand what happens in an ACAT, what an ACAT is, or an aged care assessment team is?
In my experience, people don't understand what it is unless they actually have to be
It's a black
involved
box
in it.
that you order
That's
up.
Right. That's right. And so people don't understand the value of accessing an aged care services. And in the past, people have thought that service is about me going to a nursing home and I'll avoid that at all costs. And in fact, the aged care assessment program's about keeping people at home and resourced and as healthy as possible. So there have been myths about the aged care assessment program, and people have hesitated to access them. But I think I can see over time trends are changing, and more people are wanting to access themselves to aged care assessment teams, which can be a problem also because we can't see all older people.
Is that an issue in Aboriginal communities? Is the sort of same thing mirrored?
I think it's really important to find an access person within the community. So a lot of people may say, oh, we need aged care. They don't necessarily know what carers respite, ACAT, HAC, to differentiate between them. So to actually identify and employ one person in the community that can be an access point for the people within the community and all the outside services.
Who understands what's going on.
Yeah.
So who should be referred?
The target group for aged care assessment teams is usually frail older people and their carers who have complex health problems.
That word again, frailty.
Yes, complex health problems, frailty, and issues caring and managing in the community. And those people who are at risk of coming into hospital repeatedly or having accidents and injuries at home, or those people who are prematurely looking at going into residential care because they're not well supported.
To what extent do you find that referrals are late?
To a great extent. I mean, the capacity of the aged care assessment program is such that we usually see people at that later end, which is unfortunate. There's not a lot of opportunity to get out there early and do a lot of intervention early in the piece, which is primarily what community health programs in primary care are doing, and looking at some healthy ageing strategy and lifestyle strategies to try and help people.
So do you think if you called aged care assessment teams in earlier, you could actually make a difference and keep people at home longer?
Yeah, often if someone is referred to us early, either we may do an assessment or we may be able to identify at that point that another community health program perhaps may be more suitable for them, and we can help them access that.
Now, there's a lot of variability about who's in the aged care assessment team.
It varies certainly across Australia. Some aged care assessment teams have big teams with a lot of allied health and nursing and doctors. Other teams, like in remote New South Wales, have just one multi-skilled, usually a nurse out there. There isn't a lot of access to allied health, but they're usually part of a bigger team.
And how does the geriatrician relate to the ACAT?
Well, there should always be access to a geriatrician, but there frankly isn't, because the geriatricians are concentrated in capital cities around Australia. Some aged care assessment teams have a geriatrician within the team, others have access to one.
And often we do that through telehealth to access geriatrician services in remote and rural.
And the relationship to the GP, you're just the referrer, are you?
With the ACAT? We are. But you find that the more you have to do with the ACAT service, the more there's a reciprocal sort of relationship develops. Now,
there are several purposes really for the aged care assessment team. One is you're the gatekeeper for government-subsidised services. Mm-hmm. Is that the only thing that you do?
No, being a gatekeeper for those services is all about really, that's the end of the assessment process and looking at what of those services someone might actually need to access. The whole point of the aged care assessment program is to undertake very comprehensive assessments with older people and their carers and their families, engaging all the people that are important in their life and getting to the nuts and bolts of where the person's strengths and illnesses are, and their weaknesses, and looking at how we can improve their health and their lifestyle and keep them at home. And we may need to use some Commonwealth subsidised services, in which case we look at their eligibility and helping them to access those.
So take us through those services that you are the gatekeeper for, because they've got names like transition program, community care packages, and of course residential care. Yeah. But what do they actually mean? Let's start with transition programs. What are they?
The transitional care program is a joint Commonwealth and state program that actually provides therapy-based services for older people who may be in hospital and needing just a little bit more time than they can spend in an acute hospital to recover, to recuperate and reach their potential, and then look at getting them home supported or into a less supportive residential care services. But it's about giving them some time to recuperate and get a whole lot better, so we can look at what their future needs are.
And in the country where there aren't maybe step-down services, subacute services?
Often some of the small hospitals in the remote areas do that sort of process as well.
It's true, because sometimes you hear it's easier to get in those services in the country than it is in the city.
Yeah.
And is there? But there's a home element to the transition program, isn't there, where you can you can parachute in quite intensive care to the home?
That's right. The transitional care program can be in-house, where it's run in an institution, or a facility where there's beds, as in a hospital, or it can be done in the community. But in fact, it's a flexible program in that some people may start off in a hospital transitional care program and transition into the community over a 12-week period. So it's very flexible and tailor-made for that person.
And in Aboriginal communities?
We don't actually have the transitional care program. That's in some areas of Western Australia. So to actually get 24-hour care and things like that's not going to happen. You've got the clinic nurse there, the Aboriginal health worker, and occasionally a remote HAC service as well.
So community care packages, what are they?
Well, there's low care packages, which equates to hostel type care, that low residential care facility, but in the home, and they will provide a flexible set of services, as in helping people with meals, their personal hygiene, domestic duties and transport and such. And then there's the high care package, which is the EACH, extended aged care at home packages, and extended aged care at home dementia packages as well. And they're a high care package that can go into someone's home 7 days a week, a few times a day, and certainly, up to late in the evening. And they equate to having high care in a nursing home, but it's available in the community. There's some restriction on that. Some people just are a little bit too high care need to manage in there, but that has made a significant difference to how soon people go into high care residential care.
And how tailorable is it to individual needs?
Look, in my experience, the ACATs services work very closely with all the service providers. So at that point that it may be recommended that one of those packages of care is needed, the ACAT would work with that service provider.
Oh, so you're not just doing the assessment, you're doing a bit of coordination afterwards?
Absolutely, that happens after the assessment process. We coordinate people and their families to the point where some other service can take over their care.
So does that describe what happens in your country town, Max?
It does. I would say there's a few caveats there. I think particularly with the EACH packages, you really need to have a full-time capable carer at home to make that work, because there's just no provision for care after hours. So it's not quite the same as having sort of high-level care in an institution.
So it's really...
EACH packages in remote Australia at all. Yeah.
So really that's the ideal, and you apply it as well as you can given the workforce you've got.
That's right.
So even if the money's available, you may not have the workers to actually do it.
Yeah.
So tell me what happens in an aged care assessment. You come into the house.
We go into the house and we ensure that people understand what the process is, and that is that we're going to, ask a lot of questions about their health and their lifestyle.
Just let me interrupt a second. So this is different from, say, the OT, having to walk around the house and looking for where you need rails and where there's trip points and things like that.
This is probably at the point where we sit down and work out just exactly whether they need OTs and what else they need. It's having a look at where things are going wrong, where they're going right, and try and marry them up so that we can actually improve things, intervene to try and keep that unit supported with sufficient
So there's been a bit of
service.
criticism of aged care assessment teams that there's variability between them. Are they supposed to use validated tools for that, so that an assessment in outer metropolitan Perth is similar to one that you might have done in Dubbo in New South Wales?
I think there's been a lot of variety over the years, but there's been some recent reforms to the aged care assessment program, and now we're looking at a consistency of practice and assessment, and we're currently looking at some consistent assessment tools that are validated and can be commonly used, so that we're all speaking the same language, and people in one part of Australia can expect the same from an ACAT in another part.
And can families refer themselves to ACAT?
Anyone can refer to the ACAT as long as we've got the client's consent, and then when we engage the person to do an assessment, we need to ensure we have their consent and they apply for a service that they may be wishing us to, do that assessment for.
And what about urgent referrals?
Within the aged care assessment program, we have a national triage program where we can actually triage referrals in terms of urgency, ranging from within 48 hours to 3 or 4 weeks. So we actually, see people on the basis of need and urgency.
And Max, have you got any tips, given you've worked on both sides of the fence, tips for general practitioners dealing with aged care assessment teams?
Yes, certainly. I think one is to get to know your aged care assessment teams personally, and then acquaint yourself with the range of services that are out there for aged care, which often you don't know about instantaneously. So I think once you get to know and work with the ACAT team, you can use them more intelligently. You can, and sometimes you can actually save the ACAT some work by actually making small referrals beyond, outside of that. What
about in the other direction, Jane, from the ACAT to the GP? Because you've worked with aged care assessment teams.
Yeah. Look, I think it's really critical that the aged care assessment team will sometimes go into a home where there are real problems that have not been picked up by a general practitioner, and working with the general practitioner to feed in more information. For example, dementia is the case in point. Very hard to diagnose during a brief consultation in the general practitioner's rooms, but may be very obvious in the home. So if the general practitioner is available for consultation with the aged care assessment teams, it's got to be a better outcome for the patient, the client.
So what are you implying behind that? It's sometimes hard to get back to the GP?
Well, it may indeed. General practitioners are likely to be busy. Their secretaries, in fact, may perceive themselves to be barriers to people ringing up all the time. So making themselves available, I think, has got to be in everybody's best interest.
Max, what systems do you set up in your surgery, in your practice, to facilitate that sort of communication backwards?
One of the tools we often use in our practice is actually to use a 75 plus health assessment to look at our own clients.
I'm talking about more when
we're talking to
the back channel from ACAT to you. You know, the difficulty sometimes they find communicating, not necessarily with you, but with GPs. Do you have you set anything up that allows that to be easier?
I think one of the easiest ways is for them to actually sort of fax information to us. Because then it's not actually interrupting the consultation, but that gives you time then to actually respond and ring them back and talk about those issues when you've got a bit of time.
And often ACATs can schedule family discussions and case discussions around the GP schedule to try and engage them as well. So it's a two-way thing.
But you can use enhanced patient care items here.
And this sort of family conferencing would be a point in case.
Right. Tell me about the delegate.
The delegate is, they're in the aged care assessment team. There's certain staff that are trained in delegation. There's a training program, the delegates training program, which we're all using now. And that is about following the Aged Care Act and ensuring that people who are applying for services are assessed using the Aged Care Act and the criteria, and ensure that they're entitled to services and they receive them as necessary. It also ensures that the clients know that their options for appeal are available, and that the delegates actually act as the Secretary of the Department of Health and Ageing. So they have that authority to approve services for somebody and to activate the funding for that service provider.
And just overall, what are the different patterns of adaptation to the sort of aged care assessment team in rural areas, given the limitations that you often have in terms of workforce, distance and that sort of thing?
I think we use, as I say, we use a lot of technology now in telehealth and other sorts of modes of connecting with other service providers and other ACAT teams, and pooling our resources and using each other like that to always improve our capacity as a team. And we use a lot of community health and other service points where there are other specialists that we can assist us in making sure that our assessments of older people are very comprehensive.
I think another thing that people in more isolated aged care assessment teams do is that they multitask a lot more. I've sat in aged care assessment team meetings in several rural areas, and it's often very hard to say who is the nurse, who is the occupational therapist, who is the physiotherapist.
And who's the patient?
Indeed, they're not there, but potentially.
Sorry.
Yeah.
So, in a much more flexible, and in Aboriginal communities, I mean, what you're describing here, Kate, is a situation where, with the best will in the world and even with the money on the table, you can't get the services on the ground.
Well, instead of being called an aged care assessment person, we were called the aged care clinician, because we also were involved with a lot of CACPs. Community aged care packages. So I'm looking at the provision and the needs for people who are hostel and nursing home level, living at home. And of course the aged care assessments as well. But yeah, there is Carers Respite Centre and community aged care packages available. It's just having the people there on the ground to be able to deliver the service.
Right. Let's go to our first case study. Stefano is 90 years old. He came from Italy to live in the Riverina and now lives with his second wife, who's Rosa. She's 81. They've got no children together, but Stefano has a son from a previous marriage. He lives interstate and visits about 3 times a year and doesn't get on that well with Rosa, particularly about the father's care. Stefano's becoming a bit confused. Rosa doesn't like leaving him alone because she was worried about his safety, and he's still driving occasionally. Rosa is his full-time carer and has enduring power of attorney. Stefano is adamant that he doesn't want to go into residential care, but he comes to the local hospital after a fall. Rosa's with him, and she's pretty tired and stressed out. Max?
Thanks,
You're
Norman.
on.
I think there are 2 major issues here. One is what's happening with Stefano. Is he acutely ill and having a fall as a result of that? Is the process more subacute or even chronic? Does he have dementia? Does he have depression or delirium? So the first thing you've got to decide in this sort of situation is there a medically reversible cause for his presentation? The second issue, of course, is Rosa's sort of exhaustion and burnout. That will depend on what sort of level of service provision you can give to support her, and also how quickly you expect Stefano to get better, if indeed he's going to get better at all.
So is the fall enough of a trigger to say he needs a proper assessment?
I think absolutely. A fall it's a geriatric giant. 1/3 of the elderly community will have a fall every year, but once you've had more than that, then I think the odds are you've got frailty.
Jane, talk to me about delirium.
Well, people with dementia have low reserve, and so a little thing is going to throw them off their perch, metaphorically speaking. So if those of us sitting on the panel developed a urinary tract infection or constipation, we would come to work, people wouldn't notice any difference. But somebody with dementia will be vulnerable to any minor insult. And so a simple thing, and it might not even be a physical illness, it may be the grief of the daughter not visiting anymore or the dog dying. These things can scramble the brain. An acute scrambling of the brain is what we call delirium.
But it's under-recognised, isn't it?
It's certainly under-recognised.
How does it manifest?
Well, the difference between dementia and delirium is that dementia starts almost imperceptibly, happens over a period of time, fluctuates somewhat, but it's a relentlessly downhill course, lasts forever. Now, delirium is something that starts suddenly. So on a background of dementia, it may be hard to pick it up, but there will be a noticeable difference, and it may have happened within hours or days. The hallmark of delirium is that it fluctuates quite markedly. And the classical story, say in a hospital, is that the doctor comes along and does a ward round, sees the patient for 5-10 minutes, patient seems quite clear, goes off, but every night the poor hapless nurses are dealing with a man who's roaming around the hospital. So delirium by definition starts suddenly, it fluctuates a lot, and what many people don't appreciate is that delirium may last for a long, long time, and in a number of cases may in fact be permanent.
Permanent? Because I always thought of it as a preventable phenomenon.
It may be preventable, but it may also be permanent.
Max?
Yes, I think the concept of the weakest link comes in too. So if you're a frail elderly person with mobility issues, if you get ill, you'll have a fall. If you've got problems with continence.
So how are you going to tell whether Stefano's delirious on this admission?
Well, I think the first thing to do is to actually do a very careful sort of physical and clinical workup to see if you can find, 95% of cases are due to either drugs or bugs, so you'll be looking particularly for those causes.
I mean, what I'm going to hear, Deborah, is you need consent for an ACAT, don't you?
You do. You need to get consent from the client themselves, ideally, but if their capacity, whether it be a temporary incapacity due to a delirium or a dementia, we need to then work with their person responsible, whether that's their carer or their next of kin, whoever's responsible, to get consent for that assessment.
Could you do an assessment on Stefano without Rosa present?
It would be not ideal to do that, because Rosa certainly has a significant input into his life. But in terms of assessment as for cognition, there would be a period of time that you'd want to engage just Stefan on his own to get some unprompted, influenced answers from him,
So
and then confirm them with Rosa.
So the son phones you up and says, I don't trust Rosa, I don't want her there.
In this situation, often people are brought into hospital. There's been something go on before they get there, and certainly a fall is one of those things that sets everybody's alarms off and say this person needs to go into care. And that's often where a family who, you know, is a little estranged may say, this is it, this is it. Older people need a little bit of time to recover from an acute illness, and we need the carers to have a bit of a break. We need things to settle down and things to be treated, and the person to be medically stable before we engage in that sort of future planning about what sorts of things he needs and he wants and what's suitable for him. So we don't usually jump in at that very first point where they're acute and everyone's emotional.
I think the critical factor here is that the diagnosis of neither dementia nor delirium is going to be made by one-on-one testing with a health professional and a client. It's got to be made on the history, and this is a classical case that brings into focus the importance of bringing together the son and the wife and the client, potentially, General Practitioner as well, any of the service providers in the community that may have been involved, to find out what was going on, not just during this hospital admission, maybe almost irrelevant, what was going on last week, last month, last year.
So the enduring power of attorney gives, it's different for different states, gives Rosa what authority here?
Rosa has, with power of attorney, power to act on the finances and the home and things, not about lifestyle or what care options or accommodation.
So it's not about consent?
No, it's not. But she's certainly the person responsible, and you know, but it doesn't give her legal authority over making those decisions.
And what if there's a huge row between the son and Rosa here? And the son's saying one thing and Rosa's saying the other. How do you deal with that in the aged care assessment team?
I think it's what we tend to do with conflict resolution is ensure that everybody has had time to get rid of their, you know, stress and emotion, and bring together and help them understand what's perhaps best for Stefan, what Rosa's needs are, what's the son's needs, and help trying to work out what is a plan that's going to suit everybody but has the best outcome for Stefan as well.
What happens, Max, when the aged care assessment team thinks, well, Stefano for 90 is not too bad. You know, he's a little bit confused, he's a little bit unstable, but you know, he could be at home. Mm-hmm. And Rosa says, I'm throwing in the towel. You know, mm-hmm. he's got to be in a home. I can't do this any longer. Because in the end, if a carer walks away, you're in the same boat anyway.
That's right, exactly right. So I think if Rosa is not prepared to do it, it's not going to work sending him home anyway. So I think in a situation like that, it's really important to try and work out the capacity. If Stefano hasn't got capacity to make reasonable decisions for himself, then it falls back, in this case, to Rosa. If there's a huge conflict still between the son and Rosa, then that issue will probably have to go to the Guardianship Tribunal to get an independent assessment.
This is in New South Wales.
This is in New South Wales.
Legislation is different in different states. And what sort of carer support is available for Rosa where some time out might actually allow her to get things into perspective?
You're talking about out of hospital?
Yeah, no? Well, I mean, to actually, you know, cut the vicious cycle for Rosa.
Usually respite, I would think, in the first instance.
There's residential respite in an aged care facility, either high or low respite, but also the care respite services have a lot of options of in-house respite, and that is sometimes overnight and for a few days at a time, where the person who has a cognitive impairment is able to be managed at home in the absence of the carer, in a place where they're familiar and comfortable and will function better. And there's a lot of combinations of those sorts of respite. There's also day centres and activity centres that can offer respite on a long-term basis.
What are the sources of information here?
The care respite services and the CareLink services are across Australia now, and they can instruct people about where the best combination of services can be found, what services provide what. Also, the Aged Care Australia website is for consumers, and they're able to log on there and find out what services are available, what to do if they are in need, who to go to, who to contact. And also for professionals, there's the health website where they can look at the legislative requirements for referral and all those sorts of things as well.
Final comment on Stefano, Jane?
Well, I think bringing this family together is really important if we possibly can. Dementia is a really good way to drive families apart. People bring with it their own burdens. The son may well be bringing the guilt. He may not have seen his dad for a while. He's been harbouring resentment to the wife, the new wife.
This young chick who's come in at 81 to take over his dad.
Who's taking his inheritance as well. So if we can, and critically I think, what we need to do is to make sure that they all know what's going on. If this is a case of dementia, then they've lost their dad as he was. And so imparting that knowledge so that they've got a way of finding out what's the truth might help them.
Let's go to our second case study. It's Mary. She's 87 years old, pensioner, living by herself but independently in a country town, population of about 8,000. She's been a widow for 5 years. She's got 2 kids, one son who lives interstate and the daughter lives locally and visits once or twice a week. She was hospitalised after a fall, that's Mary, and had a fracture and has had 3 falls in the last 3 months. They usually occur at night. She uses a walking stick but is forgetting to take her medication. She likes a drink. She has 2 or 3 glasses of wine every night and thankfully no longer drives. A hospital-based aged care assessment team has assessed her and offered the following care options for her: a community aged care package, entry into a low-care residential aged care facility, or entry into the transition care programme. Following an ACAT multidisciplinary case conference, the delegate approved Mary for a community aged care package. So the aged care assessment team's been having a 5 bob each way on Mary.
Perhaps. You know, there are a few issues here you need to be sort of sorted out. I think my suspicion here would be one of someone who's got some sort of cognitive impairment and who's overusing or misusing medications and alcohol. Some elements may be reversible, some may not. So whether or not that's the right call and she does need residential care, or whether in fact there's a degree of significant recovery and she could go home with some support, needs a bit of more time in sorting out.
So Deborah, this is one of these situations where time will tell.
That's right. Often there's a number of options that people think that might suit this person, but until you've had an opportunity to sit down and have a look at the entire holistic view, it's difficult to work out what the care plan is that actually suits this person and might work for this person.
And a classical scenario here is that this woman is drinking 2 or 3 or maybe 6 or 7 glasses of wine a day. She's got little insight. She may, as Max said, be suffering from dementia. Now, what's her daughter going through? The daughter may be carrying a huge burden, and you certainly don't expect somebody with dementia to have compassion and understanding for the daughter. So working out what's safe and what's reasonable for this woman. We want to give her autonomy, but we also want to recognise the sort of burden that the daughter may be carrying.
What would you do for her medically?
I think the first thing I would do is review her medications. I would certainly suggest that medications be put into Webster packaging so that there's less room for error. I would certainly
And in a medication review, are you allowed to remove the wine?
I'm just about to say, I think I would encourage the daughter to actually take charge of how much wine gets into the house. I think, in fact, the cask wine is probably the worst trap for people with dementia because they forget they've had the first and second glass and they've got no way of...
And there's 2 litres still left in the fridge.
Exactly.
Deborah, what do you do if she says, well, I don't want anybody in my house, thank you very much. I'm managing quite well and I don't want anybody in.
Yeah, and that's pretty common in older people, and certainly I feel the same way too. I don't particularly want a wad of people coming in. Often we negotiate with the aged care, in this situation, aged care package provider, to slowly meet that older person and slowly just go into their home, little bit by little bit, befriend them, get their confidence and start to do little things for them. And certainly to connect with that daughter as well, so that she actually provides that support for the daughter in the home with her mother. And slowly but surely, when an older person who is very resistant in the beginning will accept someone in their home and invite them in a little bit more and a little bit more, and then the care gets put into place slowly.
And how would you know if she's depressed, Jane?
Well, doctors have got ways of working out who's depressed and who's dementing, but I think it pretty well comes down...
It's hard though if you got both.
Well, it certainly does, and people with dementia are more prone to getting depressed. Indeed. In fact, it's often a prodrome for dementia. But it's not going to be a matter of doing a test and saying, yeah, we got 4 out of 10 on that test or 7 out of 10, hence they're depressed.
It's a global impression.
It's a matter of talking with everybody else, getting the story.
One thing I didn't ask you earlier, Deborah, is cost. You know, if you're on a pension, what out of pocket are we here? Just give me a sense of the cost of these packages, what you might be out of pocket on.
Certainly people on an aged care pension or equivalent are able to manage the costs of these services quite easily. That's why they're Commonwealth subsidised. And the service providers do their own income to determine what the person can afford, and there are caps on those costs by the Commonwealth.
I thought that was for residential aged care, but even for community aged care packages, there's an out-of-pocket?
There are caps, and there is money involved in paying for the packages as well, but it's certainly less than residential care that they need to pay. And nobody's disadvantaged by the inability to pay. You know, there's always...
So do you have an asset test for community aged care packages?
No, I think it's more of a local assessment done by the service provider about what the person can pay and what they, you know, they can charge within a set period, within a set cap that the Commonwealth implies.
What about waiting lists for services, Max?
I think it's very largely depending which part of the country you're in. I know the waiting time for ACAT, sort of a routine ACAT assessment in our area would be of the matter of 2 or 3 weeks, but you know, there is provision for urgent assessment if need be.
So where does the transition occur? Using transition not in the term of the programme, but so let's say you try out this community aged care package with Mary, and it's going to go on. And you've started off with the aged care assessment team doing their case coordination or their care coordination. Does that go on forever, or do they have to transfer to a case manager? How do you transition to the more permanent arrangement?
Well, the providers who provide community aged care packages actually take on that case management role once they've engaged the client and they're providing the care. They monitor the client's care and they certainly can refer back to the aged care assessment team if the person's needs get greater than what they can provide. But the aged care assessment team is only involved up to the point where that service provider for that service takes over the care of the person.
Jane, what factor does squalor play in this? The fact that sometimes the reason that Mary doesn't want you to come in is that she's been hoarding newspapers since 1942 and never thrown out a paper bag from Woolworths.
Well, one of the reasons for calls I get from aged care assessment teams is that somebody is living in squalor. Now, there are some people who are messy and who live in squalor, but in general, people who live in squalor have got a problem. And there are some forms of dementia, predominantly we call those frontal dementia or frontotemporal dementia, previously called Pick's disease, where people may present quite well, their memory may be quite good, they don't look like anybody else with Alzheimer's disease, but they may well live in squalor. So an assessment by a senior clinician at that point, when there is squalor identified, I think is very important.
Max?
I totally agree. I think the people that lose that executive function, that frontal function of the brain, are the ones that often end up in squalor.
Yes, so. But then again, there's a lot of people who live in even humpies and makeshift homes that most people wouldn't approve of, but they live happily, that's their choice. They're cognitively able to make that decision, and they're not excluded from receiving whatever care we can access to them as well.
But again, I think
when they're functioning.
Yeah, history is important, because if they were always a tidy person and suddenly were living in squalor, that's different.
When there's a change.
So talking to a family is so important.
Is the house ever pristine with dementia?
Yes, absolutely. There are some people who have had a very obsessive life, who've been very good at housework, who keep an absolutely impeccable home, and yet they're locking themselves out all the time. The fridge may be stacked full of meals on wheels, meals that are never eaten, or they may be wasting away. The quality of the home is a guide, but it's only one part of the guide.
So don't be misled by if you could eat off the floor.
It's those meals on wheels that are stacked in the fridge that turn green that start to tell you that there's some problems here and things aren't as they were.
A good service is the Dementia Behavioural Management Advisory Service. It's around rural and remote areas. So if family or the client are expressing that there's behavioural or psychological symptoms of dementia that they need assistance with, you can either make a phone call or ask these people to come out and give you advice on some management strategies.
Good, useful advice. Let's go to our next case study, who's Joe. He's 63 years old and lives in a remote Aboriginal community whose preferred language is Naranian. And that means he comes from the Kimberley. Joe's retired and previously worked as a drover and horsebreaker. He's been predeceased by his wife and 2 of his 3 children. His son, his one surviving son, lives in a town 450k away, and he visits about a couple of times a year. Joe had a stroke and was flown by the Flying Doctor Service to Perth. That's 3,000k south of his community, and he was in Perth for about 6 weeks. He has mild cataracts, high blood pressure, and a past history of Hansen's disease. He's returned to the community with mild left hemiparesis and is able to walk with the aid of a walking frame. His nephew Bert is assisting with his care. The community clinic nurse has contacted the aged care assessment clinician in the nearest town being 300 kilometres away on an unsealed road, informing them of Joe's return and requesting an urgent assessment. You get the call, Kate.
Well, my first question would be, why is it an urgent assessment? And also, perhaps, why didn't I get an earlier referral from the discharging hospital? Following that...
That's life, Kate.
That's just life, yeah. Keep working away on it. Following that, I'd find out a bit more from, probably call the Aboriginal health worker at the clinic, find a bit about his background, and also about a bit more detail about his weakness and past medical history. I'd then plan to go out to the community, so that would involve calling the community and asking for council approval to visit the community, and also asking if a male Aboriginal health worker could travel with me to the community. If your ACAT hasn't employed a male and female Aboriginal health worker for gender issues, then I suppose you could work with the community council and see if...
So even, I'll come to Deborah now, I mean, Kimberley's, you know, there's diversity of communities in Kimberley, but there's huge diversity in a large state like New South Wales.
There certainly is.
Having one male Aboriginal worker who may be from not anywhere near that particular community, and I know we talk about cultural safety, does that provide cultural safety even if they're not from the community?
No, even if you are an Aboriginal worker of some sort, you actually still have to be accepted by that community, and sometimes we do have Aboriginal workers that can't work within certain Aboriginal communities because they're not accepted for whatever reason in that community, and they're not as effective as somebody who the community has, you know, approved of.
So just having ticked the box on having an Aboriginal health worker is
not always the answer
sufficient.
at all. In fact, it can be detrimental.
So you've got to be careful.
Yeah.
It's important to start with, so for example, if your cultural awareness training is really important, but that can be so specific to an area. But one good thing about cultural awareness training may be that it teaches you to build relationships with communities. So finding out about your community, about the traditional owners, the language groups, and getting that background there. And then learning about using interpreters as well. Just because you've got an Aboriginal health worker doesn't mean that they can interpret one of the 25 languages spoken in the Kimberley. So going through an interpreting service and employing that person, and then hopefully having... And
does that guarantee, I mean, the frustrating thing would be driving 300 k's along an unsealed road, having set it up and there's nobody there when you get there.
No, if Joe's not there?
No, and the interpreter's
not there. It doesn't guarantee, interpreting services don't always have an interpreter that's trained within the community. You would call that up before, call up and find out beforehand. Find out Joe's skin name, make sure the interpreter isn't taboo to Joe in relationship. And then if the interpreter isn't there...
So that would be like a daughter or a daughter-in-law? That's something
daughter-in-law, yep. Mother-in-law for Joe. And if they're not in the community, then so be it. I would then look at if the Aboriginal health worker, you don't want to overload the Aboriginal health worker working at the clinic all the time. So if the Aboriginal health worker speaks that language, then that's fine, and if the Aboriginal liaison officer. But a good thing in the Kimberley is having remote HACs, so which is home and community care. And these remote home and community care staff members are usually Aboriginal or Torres Strait Islander people. So.
So
There-
the key thing here is get the ducks lined up on the wall so that everything's there set up.
As well, I mean, it's, you know,
As well as you
it's
can.
never going to work out perfectly. I mean, sometimes it does, but yeah, as well as you can. So, and also work with other services as well. So, for example, if you're going to make this trip 300 kilometres away, perhaps call the OT and the community aged care package coordinator and see if there's anything that they need brought out. So, for example, continence aids or equipment to that community.
What do you do when you get there? Because you've developed validated tools for assessing.
There are, for the aged care assessment teams, you use a comprehensive assessment form, but within that you can use the Kimberley Indigenous Cognitive Assessment. That's an assessment developed in the Kimberley for dementia screening. And you may speak to Bert, his nephew, who says, oh, you know, my uncle's been forgetting his medications or forgetting the way to his other nephew's house. So triggers like that make you think, oh, assess him with the Kimberley Indigenous Cognitive Assessment. That was validated in the Kimberley and developed in the Kimberley, but also developed in the validated in the Northern Territory and far North Queensland. It was developed with assistance from the Language Resource Centre, so they converted the tool into Wamidori language, one of the languages spoken in the desert region of the Kimberley, and back translated into English. So changes were made, and this just makes sure that it can be used more easily by interpreters. Using an interpreter, you're assessing a person's language skills when you're assessing for cognitive impairment, so always employ the interpreter. And the kicker can be downloaded, it's free, off that website, www.watcher.org.au.
And it's got, as you say, various modalities. Presumably, Deborah, it can become quite hard for an elderly Indigenous person that if they've got a rarely spoken language and they revert to their language and forget English.
It's so with Aboriginal people as well as people whose English wasn't their first language. It's often very difficult for people with dementia, and often we have to use interpreters, but engaging services for somebody who's not understanding English anymore is often very difficult and needs a lot of community supports around them to help service providers provide appropriate care when they're there.
So both of you, give me some examples of effective Indigenous aged care services.
There's a few that I know of. In Queensland, I know the ACATs just started working with employing Aboriginal health workers. They hadn't done that before, so that's a step in the right direction. In the Kimberley, we work closely with the HAC, Home and Community Care, and community aged care packages, so they're all under the one service. And within that, there's Aboriginal people in management level and in the community that you can work with. There is a trial that we're working with at the moment in Luma community in the Kimberley, where there's a management committee that the community council is on. There's a local action group where the ACAT, a person with a disability and frail age, are on that local action group and provide cultural support. And you've got a project coordinator who's the access point within the Luma community, and you also have the essential support or home and community care workers in the community. So that's having local input at all levels.
And certainly working with Aboriginal home care services and Aboriginal community aged care package service providers, as well as Aboriginal health workers, we've been able to introduce ourselves into their communities and be involved in activities that were within that community, and slowly introduce appropriate literature, information, access points and the like, so that Aboriginal people don't fear that we won't be essentially...
So has that increased the uptake?
Slowly but surely it has. More older people, Aboriginal people, certainly in Western New South Wales, are taking up HAC services and Aboriginal specific services, not so much regular aged care services.
Now earlier you were alluding to some of the changes that have taken place in the aged care assessment program. Do you want to give us a sense of what's been happening?
Overall in Australia with the aged care assessment program, there's been a number of changes to legislation so that interpreting the Aged Care Act, there are now a number of people who don't need to be reassessed by ACAT teams, like those people who are already in residential care moving from a low to a high, and people in the community who may be assessed for a high care package, an each package, or for respite care at a higher level, they don't have to be reassessed in 12 months as they did before to see if they're still eligible for those services. That has really decreased the number of referrals waiting to be seen, so it's decreased the waiting times for people to be seen, and it's given some resource back to ACATs to be actually seeing people who need to be seen by the service.
And there are sources of information about legislative changes and so on, aren't there?
Yes, on the website, on the health website, there is the legislative changes for professionals to have a look at if they want to look at the, what's changed as far as the Aged Care Act and the legislation around that. And also Aged Care Australia has provided updated information for consumers about services and what they need from ACATs and what they can get in the aged care arena as far as services they might need. And also the aged care assessment program itself have brought in resource packages, education packages, so that all ACAT staff are trained in generic and assessor training. So it brings our standard of practice and understanding and consistency of practice across Australia to a level where it's it's equitable across Australia.
And Max, the implication for country areas from that?
In terms of
these changes?
I think principally from my point of view, more timely assessments are able to be done.
The system's less clogged.
Absolutely. Mm.
Thank you all very much. What are your take-home messages, Kate?
Building a relationship with the Aboriginal community and local services.
And I think the aged care assessment program needs to be seen as a program that can offer people interventions to improve their health and lifestyle, not just about being eligible for Commonwealth subsidised services.
Next.
For general practitioners, I think get to know the full range of aged care services, if you don't already, in your area. Get to know your aged care team on a personal basis.
And be open to their feedback.
And be open to their feedback, absolutely.
Listen to them.
And refer dementia early.
Jane?
Well, I think to acknowledge that old people have low reserve, that if we're going to meet their needs, we need to work collaboratively, get a good history, and that we've got to acknowledge who we're dealing with here, who's got the problem, what is their problem, what do they want, and let's be focused on the client.
Thank you all very much indeed. Fascinating programme, and I hope you found it too, this aged care assessment programme. Our thanks to the Department of Health and Ageing for making the programme possible, and thanks to you for taking the time to attend. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the evaluation form. I'm Norman Swan. Bye for now. The next Rural Health Education Foundation programme will be on Tuesday, March 9th. It's the second programme in a 4-part series on the new musculoskeletal clinical guidelines called Rheumatoid Arthritis, Clinical Guideline for Diagnosis and Management. Following that, on Tuesday the 16th of March, will be Recovery from Trauma, What Works. This is a co-production by the Rural Health Education Foundation and the Australian Centre for Post-Traumatic Mental Health, and it won a Freddie Media Health Award at the 2009 International Health and Medical Media Awards. We hope you can join us for these programmes. And don't forget, for any further details about the content or schedule for upcoming programmes, log on to rhef.com.au.